All right, let's jump straight into today's explainer. We are taking on a massive, highly tested topic, enteroviruses and polio. If you're gearing up for the boards or a major exam, you know exactly how high yield this is. We're going to do a rapid fire review to make sure you can instantly spot those classic clinical buzzwords and honestly, more importantly, dodge the tricky traps test makers love to lay out for you. Let's lock this in. So here's our game plan for today. We'll hit enterovirus survival basics, trace polio pathogenesis, weigh OPV versus IPV, map out the high-yield clinical syndromes, and cap it off by dodging those specific exam traps. Okay, Section 1, Enterovirus Survival Basics. Let's set the ground rules for this viral family. So, enteroviruses belong to the Picornaviridae family. Right off the bat, they are single-stranded, positive-sense RNA viruses, and they're completely non-enveloped. What does that actually mean for you on the wards? Well, standard alcohol hand sanitizers just won't cut it. You absolutely need chlorine cleansers to wipe them out. But here is the absolute most critical takeaway. For enteroviruses, your humoral immunity, not your cellular immunity, is the main line of defense. Keep that tucked away because we're going to see why that's a huge deal in just a bit. Now, the name enterovirus literally gives away its superpower. Entero obviously implies the GI tract, right? But to spread via the fecal-oral route, you have to survive the literal acid bath of the stomach. And these viruses do. They are incredibly acid-stable. You'll definitely see test makers try to contrast this with other viruses, like rhinoviruses, which are acid labile and get destroyed. Enteroviruses basically wear armor against gastric acid, and that's their exact ticket inside. What's really wild, though, is just how sneaky these viruses are. Check out these numbers. Over 90% of poliovirus infections and more than 50% of non-polio enterovirus infections are totally subclinical. I mean, the vast majority of people who catch this never show a single symptom. It's a crazy statistical hook, but it perfectly explains how these viruses can spread through a whole population totally under the radar. Moving on to Section 2, let's look at poliovirus pathogenesis. All right, let's track the big boss itself, poliovirus. When you're reading a clinical vignette, I want you to picture this exact roadmap. The virus enters and hits the GI epithelium first. Then it sets up shop in the lymphoid tissues. Think tonsils and Peyer's patches. From there, it drains into the lymph nodes. And around day 3 to 5, boom, you get viremia, meaning the virus is in the blood. Finally, the ultimate destination. It crosses into the central nervous system, zeroing right in on the anterior horn cells of the spinal cord. So for the tiny fraction, less than 1%, who actually get paralytic polio, the destruction of those anterior horn cells causes a super distinct presentation. You absolutely need to associate these buzzwords right now. The paralysis is asymmetric, and it is flaccid. It's going to hit the proximal muscles way harder than the distal ones. And here is the kicker. It is a pure motor deficit. No sensory loss at all. If a question describes a paralyzed patient who can still perfectly feel a pinprick, you're almost certainly looking at polio or something just like it. Let's squash a massive exam trap right here regarding post-polio syndrome. This shows up like 20 to 40 years after the original paralysis as brand new weakness and fatigue. Why? Because the motor neurons that worked overtime to compensate for the original damage are basically just burning out. You have to remember, this is not a viral reactivation. Don't fall for that. There's no sneaky virus that's been hiding in the shadows for 4 decades. Okay, Section 3, OPV versus IPV. This is such a classic immunology showdown, the trade-offs of the OPV versus the IPV vaccines. On one side, OPV is a live attenuated oral vaccine. Its superpower is that it uniquely induces intestinal IgA, which gives us amazing mucosal herd immunity, but it carries a tiny risk of vaccine-associated paralytic polio, or VAP. Now, on the other side, IPV is a killed injected vaccine. You sacrifice that mucosal IgA, but because the virus is dead, the VAP risk is absolutely zero. It's totally safe for immunocompromised patients. And just to put that VAP risk from OPV into perspective, it's about 1 in 2.5 million doses. Super rare, right? But, and this is a huge but for exam day, that risk skyrockets 2,000-fold in immunodeficient patients. That right there is exactly why IPV is the go-to in developed nations and for anyone with a weakened immune system. Let's transition to Section 4, high-yield clinical syndromes. Okay, lightning round. Take a mental screenshot of this mapping right now because pattern recognition is everything on the wards. Hand, foot, and mouth disease? That's primarily Coxsackie-virus A16. What about severe spasm-like chest pain, aka pleurodynia? Think Coxsackie-virus B, and remember Coxsackie B is also the main villain behind severe neonatal myocarditis. Oh, and if you see acute hemorrhagic conjunctivitis, instantly link that to Enterovirus 70. Now here's a highly tested clinical distinction. How do you actually tell oral lesions apart? Well, it's all about real estate. Herpingina from Coxsackie-virus A gives you these grayish-white lesions on the soft palate and uvula, so the back of the mouth, and crucially, there is no gingivitis. Contrast that with herpes stomatitis. Those lesions are right up front in the anterior mouth, and you'll see intensely inflamed, bleeding gums. If you just remember front versus back, you'll nail that discriminator every single time.
We also can't ignore the heavy hitters when it comes to severe neurothreats. Enterovirus 71 is infamous for massive outbreaks in Asia, causing severe brainstem inflammation, or rhombencephalitis, which is tragically often fatal in kids. And then there's Enterovirus D68. This one causes acute flaccid myelitis. It's basically a modern-day polio that attacks those exact same anterior horn cells we talked about earlier, leaving patients with permanent neurologic deficits.
Finally, we've made it to Section 5, Avoiding Exam Traps. Let's make sure you don't get tricked. Let's do a quick simulation of a question you will absolutely see. A patient comes in with an acute fever, a pounding headache, photophobia, and a lumbar puncture shows lymphocytic pleocytosis. Okay, so what is the CSF glucose level going to be in this case of viral aseptic meningitis? I'll give you a second to lock your answer in your head. The answer is completely normal glucose. Look, enteroviruses cause up to 90% of aseptic meningitis cases. The absolute fastest way to tell this apart from a deadly bacterial or fungal meningitis on a lab report is that the glucose won't be tanked. It will be perfectly normal. Do not let them bait you into picking a low glucose number for an enterovirus infection. Let's tie this all together with one last trap. Remember way back at the start when I said humoral immunity was the key defense? Well, because of that, patients with A-gamma-globulinemia who don't have antibodies are incredibly vulnerable to chronic, severe enteroviral CNS disease. And if the question asks for the next step in management, remember that glucocorticoids are completely contraindicated. You'd literally be turning off the only immune response the patient actually has left. So, we've broken down the virology, mapped the pathogenesis, weighed the vaccines, and tackled the highest yield clinical syndromes. You've got the exact toolkit you need to decode these vignettes now. So, my question to you is, which of these enterovirus traps is going to be sitting there, waiting for you on your very next exam or patient encounter? Stay sharp, trust the patterns we just went over, and you are going to absolutely crush this. Thanks for joining me on today's Explainer.